Assalamualaikum, salam sejahtera, good afternoon to the Honorable Professors, the webinar chair, our invited speakers, and all participants for this live webinar. It is my pleasure to be an MC for the live webinar on detection of tuberculosis from human and animal perspective, hosted by Malaysia One Health University Network, MyHood. My name is Azlan Cik Ahmad from the Department of Veterinary Clinical Studies, Faculty of Veterinary Medicine, UPM Serdang. On behalf of the organizer, we wish to extend our warm welcome and thank you to our participants, guests of honor, and invited speakers for joining this seminar. For your information, today we have about 170 participants together joining this webinar. Includes industrial experts and professionals, medical and veterinary practitioners, as well as postgraduate and undergraduate students from medical, veterinary, and environmental backgrounds. All participants come together here to refresh, update, and discuss on various issues related to classical disease, tuberculosis. On human perspective, TB remains a major public health concern and alarming due to increasing in prevalence of multi-drug-resistant tuberculosis worldwide. On animal perspective, TB has a major economic impact on livestock production due to costs associated with testing and slaughtering affected livestock, as well as impact on the public health due to zoonotic. Ladies and gentlemen, to begin with, I would like to invite Yang Berbahagia Professor Dr. Latifah Hassan to deliver her welcome remarks. Professor Dr. Latifah Hassan is currently the Chief Coordinator of MyHood since 2013, as well as Head of the Department of Veterinary Laboratory Diagnostics, Faculty of Veterinary Medicine, UPM. She is a veterinary public health epidemiologist and academician at the Faculty of Veterinary Medicine, UPM. She graduated with Doctor of Veterinary Medicine at UPM and later received her doctorate degree from Cornell University, United States. She is an avid speaker for One Health and facilitates multiple interagency trainings in the country, regularly invited to speak at national and international seminars and conferences, and is a familiar face at many interagency meetings and platforms. With that, please welcome Yang Berbahagia Professor Dr. Latifah Hassan.
Thank you, Dr. Azlan. Yang Bursa, Dr. Shah, Dr. Sharina, who is the leader for the program for TB, for human and animal perspective. Can everybody hear me well? Can you hear me well?
Yes, yes. You
can. Fantastic.
Yes.
Okay, so I wanted to bid everybody a very welcome for listeners and participants for this Malaysia One Health University Network activity for this year. And Dr. Shah is the leader for this TV program. My name is Latifah. I'm the coordinator of Malaysia One Health University Network. Just for those who are not familiar with Malaysia One Health University Network, we are a network of universities and ministerial agencies. There are 17 universities in MyHood, and 3 ministries are part of the membership of MyHood. So Malaysia One Health University Network is part of Southeast Asia One Health University Network. And we have brothers and sisters from Indonesia, Thailand, Vietnam, Myanmar, Laos, Philippines, and Thailand. Did I say Thailand? Vietnam. So there's many OHUNs in the region. So we are one of the OHUNs, and our major chore or major core business is capacity building and enhancing understanding about One Health concept and undertakings in both teachings and doing our daily work to ensure that there is enough understanding about the interconnection between animals, health of animals, between health of humans and health of the environment. So TB is definitely a disease by which has been emerging for many years, even before COVID came. But when COVID came, everybody forgot about TB for a bit and focused on COVID-19. But TB is happening and gaining momentum in terms of its disease frequency in both human and also animals. And there was a lot of debate in terms of which one came first. Is it the humans causing the disease or transmitting TB to the animals, or animals transmitting the disease to humans? So there's a lot of debate and talks about that. So TB is unique in a way that it is one of the few zoonotic diseases that can be transmitted from humans to animals. I mean, translated very well. I mean, in fact, mycobacterium TB is probably more contagious or more infectious than Mycobacterium bovis to a certain degree. So, but in any case, I'm a veterinary public health epidemiologist, so that's my perspective, that's my take on it. People from the human health sector may agree or disagree. So we'll listen to all the expert opinion that we have from our speakers today. We're very fortunate to have speakers from both the human health sector and the animal health sector. And I look forward to a very active Q&A session right after the talk. I hope we have enough time for that. And again, enjoy the webinar. I hope there will be a lot of questions, and keep the interaction going between the human health, animal health, and environmental health, so that we can ensure the health of us as a whole. Thank you.
Thank you very much, Professor Dr. Latifah, for the remarks. Next, I would like to invite Yang Berusaha, Dr. Sharina Omar, to deliver the introduction of the program for today. Dr. Sharina Omar is a veterinary bacteriologist and academician at Faculty of Veterinary Medicine, UPM. She graduated with DVM at UPM and received a master's degree at Massey University, New Zealand, and doctorate from University of Leicester, UK. Her interest revolves around tuberculosis detection and host-pathogen interaction, as well as fungal diseases in animals. She has been regularly taking part as participant in One Health activities, engaging with different agencies and community in Malaysia. This is her stepping stone to lead an integrated knowledge sharing and practices in the diagnosis of tuberculosis, following her participation in trainings organized by Mahun. With that, please welcome Yang Berusaha, Dr. Sharina Omar.
Hi, thank you, Dr. Azlan. First of all, I would like to express my gratitude to all participants who have registered and joined us today, which shows that you are interested in learning or discussing on the topics that we will cover today, which is on the detection of tuberculosis from both angles, that is human health as well as the animal health. And I would like also to thank Mahun for this opportunity, for not only for me but also my team, the chance to organize this webinar session. So TB is a disease that is familiar to all, because it's not a new disease, and numerous strategies have been done and planned by World Health Organization, WHO. However, the target number of reducing it each year is not on track. So it makes the disease is actually more or less still prevalent throughout the world, and it's still worrisome to all, since the transmission is through the airborne from the droplets from the infected animals or humans. Majority of human TB cases is caused by Mycobacterium tuberculosis. However, humans too can acquire the infection through the unpasteurized contaminated milk with Mycobacterium bovis. So And M. bovis is most commonly found in cattle and as well as other animals like wildlife, especially the wild boar and also deer. So the point here that connects the human and the animals from the expansion of the farm locations, such as opening a new area of farms near the habitat of wildlife, actually exposing the animals and also humans to a spillover of tuberculosis. So here in Malaysia, a continuous effort, surveillance conducted by the Department of Veterinary Services, is one of the approach to help to reduce the occurrence or the incidences of tuberculosis. Although the number is not high, but we are still trying to go parallel with the WHO strategy, which is NCD. So this is a good approach in identifying, doing these prevalence studies each year. So we hope that this webinar actually could help at some point, will be fruitful for all of us to help in diagnosing or detecting the disease as early as possible. And we also hope for future collaboration in terms of improving the vaccination program or vaccine itself, and also to understand the human population interaction with the animals, or so that to reduce the occurrence of the occupational hazard among the workers in farm, and as well as to eliminate the TB from livestock population. So I hope that you all will benefit from this webinar, and hope you guys enjoy the webinar too. Thank you.
Thank you very much, Dr. Shaina, for the brief introduction about this webinar. Ladies and gentlemen, next we are honored to introduce our first speaker, Yang Berbahagia Dr. Muhammad Syafarin Syamsuddin. Dr. Muhammad Syafarin Syamsuddin is currently servicing the Department of Veterinary Services, DVS Malaysia, currently as Laboratory Director of Central Zone Veterinary Laboratory, Bandar Baru Salak Tinggi, Sepang, which is a veterinary diagnostic lab in Central Zone of Peninsular Malaysia. He is a certified and trained veterinary pathologist by the Hokkaido University, Japan, and by the World Organization for Animal Health, OIE. He is internationally trained and experienced forensic pathologist and becoming DVS reference officer for veterinary forensics since 2016. He is also a certified Malaysia Biosafety Officer in year 2020 under Malaysia Biosafety Officer Training, MABOT. He was the former Vice President of Malaysia Association of Veterinary Pathology, MAVP, and Asian Society of Veterinary Pathology, ASVP, 2011-2013. We also have here Dr. Zawida, also from DVS Malaysia, to present the same topic at the first topic. Without further ado, I would like to invite both Yang Berbahagia Dr. Muhammad Syafarin Syamsuddin and Dr. Zawida to deliver the first topic about the case scenario from animal health perspective. Please welcome.
Hello, Assalamualaikum everyone. Thank you, Mr. Chairman, and all for the thank you for the organizers. Okay, my name is Dr. Zawida from Department of Veterinary Services Malaysia. On behalf of my association, I will be presenting a little bit of our department's policy on TB prevention and control program. Can everybody see the slides? We are sharing the slides right now. Yes, no?
Yes, we can.
Okay, thank you. All right, okay, next. Okay, just to give a little bit of info about our department, we are under the Ministry of Agriculture and Food Industry, And the main departments are from the Department of Agriculture, Fisheries, and Department of Veterinary Services. And we are the authority for the veterinary services in Malaysia. Okay, in our department, there are 10 divisions. And for any activities about disease control, control and policies, it's under the Veterinary Biosecurity and SPS Management Division. Okay, we're going through about the policies on TB. So, bovine TB is a notifiable disease in Malaysia, according to the Section 31 of Animal Act 1953. So, all suspected cases must be reported to DBS. And the TB is part of the National Animal Disease Surveillance Program. So every year we have this program, not only just TB, but a few diseases that is important in Malaysia, that has importance in Malaysia. So we have annual surveillance program that we will cover the whole Peninsula Malaysia and Sabah Sarawak to know the prevalence of each diseases in Malaysia. We also have our Protocol Veterinary Malaysia, which is the protocol contains of the control policy of the any diseases important in the country. So in this case, it's TB. So we have the book here. So this is the protocol for TB. So we have other diseases also. Okay, the current policy that we are practicing now is to test and cull with compensation. So in DBS, we refer to a lot of protocols, laws, which is in the list. Of course, the first one is Animal Act 1953, and also we also do refer to our Directive Procedure, Arahan Prosedur Tetap Veterinary Malaysia, (PTM), and also our Protocol Veterinary Malaysia, (PVM). Okay, this is just the pictures of the books. Alright. For the current status for TB, in the year 2019, the prevalence of TB is 7%, which is 92 out of 1,308 samples were positive, reduced compared to year 2018, where the prevalence is 8.13%. So from these 2 years of comparison, can show that the effectiveness of our TB control and elimination strategy. Okay, so before this, I told you that we have our surveillance program annually, National Surveillance Program. So the objective of the program is for early detection of TB, to know the prevalence in the country, and it is also a crucial component in the control of elimination of TB. For the TB test and cull policy, we must confirm the case before we do any culling. And it's a requirement for declaration of country freedom by OIE. We follow the OIE protocols also. Okay, for sampling method for the surveillance program, this is just simple information about the surveillance program. So the targeted animal group is dairy, cattle, and buffalo. Selection of animal is based on simple random sampling. This is statistically calculated, and animals 4 months old and above will be selected for TB testing. So the test method used is a CFG, powder test, ELISA, Bovigam, and confirmation by comparative cervical toxicity. Okay, in the event of any TB disease in the country, we have our control program based on the protocol, veterinary protocol. So these are the activities, the programs that we do if there is a disease outbreak or a case. So there's always a quarantine of diseased animals. The diseased animal cannot go anywhere, must be quarantined at the premise. And the positive animal must be culled, culling and disposal of positive animals, and animal product control, where the animal products from the infected animal cannot be consumed and must be disposed. And of course, the basic biosecurity measures of the premise of the farm. And also the animal movement control, where there's a case, the area must be notified so that there's no movement in or out within the premise area. So we need to contain the spread of the disease. And of course, disinfection of the area, so to eliminate any agents in the environment. And of course, this TB is a zoonotic disease, so we need to give awareness on the workers' safety. We need to explain to them the danger of, when there's a TB case in animals, and they must go to the hospitals or clinics if they have TB-like symptoms. We must give awareness to them also. Okay, this is don't be afraid of the colors. This is just our way of disease index management on how we manage a disease from when we detect the disease until we free the disease. So it takes time, but just to summarize this program, this table, but it's just we're trying to say that we do the reporting on every stage of the index management. And so the critical part is the rate index, where it's an active index, when the TB case is tested positive. And of course, the yellow index is when the disease control is going on, it's happening, where the culling, the disinfectant, the movement control is happening on that yellow index. So when the program control is effective, so we need to say that that place has been recovered. So we have to do other testing 6 months after the last case reported. So to give freedom to that place, so this is according to the OIE. So we need to do retesting and retesting for about 3 years to get that freedom from OIE. Okay, I hope I'm not confusing you with the colors. Just the way that we work here. Okay, so that's a little bit about the control program that we did in DVS for TB control and prevention. So now I will pass this next topic about testing and postmortem and stuff to Dr. Shafarin.
Okay, thank you, Dr. Zawida. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, hello everyone. Okay, so after we listen to Dr. Zawida's explanation, a brief explanation on the DVS policy and so on, so let's move to the a little bit detail about the TB from animal health perspective. Okay, just to refresh everyone, because I know most of the audiences alert, even though Dr. Latifate, some of us maybe forget about the TB after COVID challenge. Okay, so but I'm sure everyone knows about the animal tuberculosis in general, that it should be noted that other members of the microbiome tuberculosis complex previously considered to be M. bovis have been accepted as new species despite identical 16 RNA sequences and over 99.9% identity of their genome sequences. Okay, this actually this statement to explain you how the microbacterium species in general has a similarity to each other. Okay, so in general that we know that we have many microbacterial species, and of course the one which is more public health concern or important microbacterium tuberculosis. Okay, and in our animal concern, of course, we are focusing more on microbacterium bovis, okay, which cause bovine tuberculosis, and also microbacterium avian, okay, avian, microbacterium paratuberculosis for your needs, and not to forget, of course, the microbacterium tuberculosis. Some cases occurred among orangutan, wild macaque, and so on. Okay, so next please. All right, so let's talk about the bovine tuberculosis, okay, which is more impact to the public health concern. So it is a chronic disease of animal caused by a bacteria called Microbacterium bovis, which is closely related to the bacteria that cause human and avian tuberculosis. Okay, this disease can affect practically all mammals, causing a general state of illness, coughing, and eventual death. The name tuberculosis comes from the nodules called tubercles, okay, which form in the lymph node of affected animals. So this triggered us how we connect our basic anatomy, pathology until to the name of this itself, tuberculosis, okay, called tubercles, okay. Okay, next please. All right, based on OIE information until the 1920s, when control measures began in the country, it was one of the major diseases of domestic animals throughout the world. And today, TB remains an important disease of cattle, wild animals, and is a significant zoonosis, okay, which means it can infect humans. And interestingly about the TB, like what Dr. Latifah said earlier, that it also can affect from human to animals. Okay. Later on we'll discuss more. And TB is a disease listed in the OIE, like what Dr. Zamidah mentioned earlier. Next, please. Okay, let's talk about the transmission, because before we understand, we proceed in detail about the pathology and so on, then or testing. So we must understand about the transmission. This disease is very, very contagious, okay, and spread by contact with infected domestic and wild animals. And the usual route of infection is by inhaling infected droplets, yeah, or aerosols, okay, which are expelled from the lungs by coughing. Why I mentioned droplets and aerosol? Okay, not all aerosol, because aerosol can be produced from the droplet itself. Okay, and ingesting raw milk, okay, from infected cows. Okay, this is where somehow the public health concern comes from. Okay, next. So because the cause of disease is slow, it is a slow progress disease. Okay, so taking months or years to kill an infected animals, an animal can spread the disease to many other herd mates before it begins to manifest clinical signs. Okay, therefore, in all countries, movement of undetected infected domestic animals and contact with infected wild animals are the major ways of spreading the disease. So from this understanding of transmission, we in DVS strategize what kind of surveillance program that we must carry on, and also when it comes to disease investigation. Okay. Okay, talking about diagnosis, because we are going to discuss more on what we should see, okay, when it comes to suspected case, instead of antemortem, postmortem, and so on. But let's go to the basic. Okay, why we need to detect the infected animal? Okay, because detecting these infected animals prevent unsafe meat from entering the chain. Okay. Of course, we are not epidemiologically, we are not looking only the spreading, the transmission of disease among herd of animals, but also in terms of human consumption. So that's why we want to prevent the unsafe meat from entering the chain. Okay, and also this will allow veterinary services to trace back to the herd of origin of the infected animal, which can be tested and eliminated if needed. Okay, next. So from here, it's a rule of thumb, okay, and focusing more on tuberculosis, okay. The diagnosis can be made based on history and clinical signs, gross pathology, histopathology, okay, bacterial isolation, of blood-based testing or serology, okay, and molecular, okay. So we will see this one by one, all right? Okay. Okay, I will ask to explain about the antemortem, but before I go further, I would like to bring you to see in two different perspectives, because when we are going to discuss about the antemortem and postmortem, okay, we have to think in two different perspectives. One, when it comes to disease investigation and including the surveillance activity and so on, and another one in terms of meat inspection, of course, for the human consumption, because these two different perspectives have its own approach. Okay, so when we talk about the antemortem, of course, live animal before being slaughtered, okay, or without, okay. So what are the parameters that we can see, which can trigger us to think about the TB, okay? Okay, for of course, in a dimension of disease investigation, of course, we are looking for the clinical sign, okay? That's why TB usually has a prolonged course, like I said, it's a slow progress and so on. But okay, and the symptoms take months or years to appear. And on the list of a few of the clinical signs that might be seen in the clinically infected animal, okay, which are weakness. Okay, you might see the animal emaciated or showing a weight loss, okay, and then loss of appetite, fluctuating fever, intermittent hacking cough, okay. Somehow it sounds like bovine mycoplasmosis, okay, the way of hacking cough, but it is intermittent hacking cough and more prolonged, okay, and diarrhea if it's related with the GIT, okay, and interfere the GIT, okay, and also large prominent lymph nodes. All right. However, the bacteria can also lie dormant in the host without causing disease. So this is special about the TB. Okay, next please. Again, just now I forgot one thing. Talking about clinical signs, those clinical signs you must see when you perform or you carry on your disease investigation. And for the meat inspection, okay, of course, prior to arrival of animals, it must the animal must be free from disease. Of course, must be tested and so on. So during the arrival, okay, from there we also can observe, okay, or perform the anti-mortem examination, okay, to ensure not any one of the head meets with this sign. Okay, so after we see the history clinical signs, so like Dr. Zawida said that we screen again, confirm with some of the tests. So here for the live animals, okay, the standard method for detection of TB is the tuberculosis test, okay, which is a basis of delayed hypersensitivity reaction, okay, where a small amount of antigen is injected into the skin and the immune reaction is measured. Okay, currently, talking about this, currently we are performing the Caudible tuberculosis test as a screening and detect the TB and confirm with the comparative cervical test. Okay. Later I will explain another type of test which can be used that we apply. Okay, depends on the cost effectiveness. Okay, but again, we confirm with the CCT, comparative cervical test. Next, please. Okay, talking about Carter fault tuberculosis test, I'm sure not everyone familiar about the CFT test, or some people call it as CFT test. Okay, it measuring skin thickness. Okay, using a caliper. Okay, injecting bovine tuberculin internally into the major area and measuring any subsequent swelling at the site of injection 72 hours later. Okay, so here CFT is used as a screening test. Okay, if there is positive, so we confirm it with the CCT, because in DVS policy there is a way or procedure. Once, what if the result is positive? So we confirm it with the CCT. But what if the result is doubt? Okay, so there is repetition. Okay, repetition that after 16 days, right? So the result after 60 days that we need to repeat until. But if twice we repeat and the result is still remain doubt, then we proceed it as a positive animal to be culled, right? Okay. And then comparative cervical test, CCT. Why we need to perform this? And this also been highlighted and guided by the OIE, because this to differentiate between animals infected with mycobacterial bodies and close sensitized to tuberculin due to exposure to other mycobacterium or related genera. Yeah, because comparative cervical test, the tuberculin, consists of both bovis and avian. Tuberculosis. Okay, next please. Okay, another way, of course, in doing the postmortem, of course, for in slaughterhouse, for the mixed inspection, it refers to the postmortem examination or inspection after the slaughtering process. Okay, and necropsy, we refer it as a necropsy in the disease investigation of animals. Look for the tubercles in the lung and lymph node. Okay, because based on OIE, okay, based on many studies at the same time, that lung and lymph nodes are more to be focused when it comes to the TB. Okay, of course it can go to other organs. After this, I will mention more. Okay. Then grossly we can see the non-vascular nodular carcinoma, known as tuberculosis, which may be developed. Yeah. Okay. Nodular granuloma, because let's see if you found this non-vascular nodular granuloma throughout the lung surface, you can use your hands to gently palpate the lung. Okay, and you can feel it nodular granuloma. Okay, And then, of course, the characteristic tuberculosis lesion occur most frequently in the lung, like I said now, and also the retropharyngeal, bronchial, and mediastinal lymph node. Okay, because again, let's go back to our normal physiology, the circulation, and so on. So that's why all these kind of lymph node is closely associated um, uh, with the respiratory organ. Okay, and lesions can also be found in mesenteric lymph node, liver, spleen, on serous membrane, and in other organs based on the circulation. All right. Next, please. Okay. Just to share you how does the nodular lesion look like. Okay, but as you can see in this slide, it is more severe. Sorry, not more chronic stage. Okay, because you can see the nodular lesions tend to be like cautious, okay, ataupun macam like empingan jagung lah, okay, complex, something like that, right? Okay, next please. Okay, this one I got it from the internet. Okay, sorry for this. Okay, you can see the multifoci cautious, yeah, nodule. Okay, contained in the this one is in plain, yeah. Okay, so next please. And then histopathology. So we associate what we found from the granules. Oh yeah, I forgot, because somehow when we do our postmortem inspection in slaughterhouse or doing postmortem or necropsy in the field during this investigation, we tend to see some kind of early lesion such as abscess. Am I right? Okay. So of course we commonly found this, right? Okay, and then we have to figure out and rule out whether it is related with the TB or not. So based on my, I still remember because I used to learn this when I was in Japan last time. So they practically showed the different between stages of lesions. So during that time, I noticed that those kind of abscesses usually occur in the early stage of infection, but the size of nodules are very small. Okay, you might miss it when you use your naked eye. But what you can do is again you observe and palpate most of the lung surface at the same time, and then you can feel the raised nodule. Okay, the tiny raised nodule. Okay, and when you do a cut surface, you can see that. Okay. Then yeah, back to this one. Tuberculosis granuloma usually have a yellowish appearance and is gaseous, gaseous-gaseous, or classified in consistency. Which means its appearance may be purulent. Okay, yeah, grossly we can see this. Okay, but and then the appearance may be more purulent in certain academic. Okay, so when we talking about the abscess or granuloma or granulomatous abscess, okay, so of course the histologically you might see the granulomatous lesion, which consists of the multinucleated Galen cells. Okay, so the multinucleated Galen cell, which you can, because this is a slow progress disease. Okay, so the time frame, the long time frame is there. Okay, so it okay, surrounding the multinucleated gland cell will develop a layer of the fibrous tissue. Okay, and that's why you can see kalau kita nampak grossly, you can see some kind of granulomatous abscess. Okay, and And these multinucleate giant cells consist of alveolar macrophages, all the phagocytic activities and so on. Okay, between this and the TB organism. Okay, addition caused by microbacterium are often possibacillary, which having few organisms. So that's why somehow when we proceed the histopathology, we will not only proceed with the H&E but also additional proceed with the Zillnison state. Okay, next. Okay, I have few pictures but not so clear. But luckily, this picture quite I got from my previous notes. Okay, this picture shows you what I explained just now. Okay, the granulomatous lesion of the from the lung. Yeah. Okay, next please. Okay, and then another way to diagnose is of course the bacteriology, okay, bacterial isolation, and also molecular. So the bacteriological examination may consist of the demonstration of acid fast bacilli, yes, by microscopic examination, which provide presumptive confirmation, and the isolation of mycobacteria on selective culture media and their subsequent identification by cultural and biochemical tests, okay, as well as DNA techniques such as PCR, which confirms the infection. Okay, next. So this is more on technical. This slide more on technical, but in general, what I can say that culture are incubate for a minimum of 8 weeks. So that's why, for a minimum of 8 weeks, okay, at 37 degree with or without CO2, and the media should be in tightly closed tubes to avoid desiccation. So I examine for microscopic growth at interval during the incubation period, and when the growth is invisible, signals are prepared and stained by the Zillnison technique. For fast. Okay, and growth of Mycobacterium bovis generally occurs within 3 to 6 weeks or incubation depending on the media used. But most of the past history, it takes more than that longer than that. Okay, next. Okay, before I proceed to this slide, just now talking about the bacteriology and molecular, one thing that we must know when we talk about the confirmation, again, earlier I mentioned about the CCT, right? Okay, CCT which we apply in the live animal. Okay, and also besides CCT, okay, we can use the bacterial isolation and of course the PCR as molecular technique to confirm the disease. Of course, the traditionally gold method is bacterial isolation of the TB organism. Molecular PCR can be used. Yeah, it is currently high demanding. Yeah, we know that, but it depends on the situation because we need to make some validation somehow in terms of different situation of cases and so on. It depending whether it is cost effective to be used or not, and so on. Yeah, this is how we do. All right. So next, just now, please. Okay, and then we also can diagnose this based on the blood-based lab test or serology. So there are 3 ways here. One is the gamma interferon assay or Bovigam for the bovine tuberculosis, which currently used by the DVS. Okay, so these gamma interferon assay or Bovigam kit, which uses an enzyme-linked immunosorbent assay or ELISA as the detection method for the interferon. Okay, And another way is lymphocyte proliferation assay, which detects cell-mediated immune responses, and also we can detect it with the indirect ELISA, which detects antibody response. Okay. Again, we have to think how which is the best way. So we follow the OIE recommendation, okay, to use the Bobicam, because one of the main reason is the high sensitivity. So once after we proceed with the gamma interferon assay, if the result is positive, then we have to confirm it. It must be followed by CCT, okay, comparative spaghetti test to confirm the positive. Okay, and that, yeah. Before we talk about disposal, of course, we have to think about what is the type of samples and sample handling. Of course, from time to time, I explain you about the lab diagnostic method. So again, I would like to emphasize again that when we talking about the screening, yeah, to detect screening process to detect the TB, okay, from the live animal, what we in department, okay, do, and based on our lab capability and capacity, so we proceed with the control test, okay, to screen whether positive or not from the herd, and followed by the confirmation, okay, with the CCT test, okay. But it depends if we have in certain I'm sharing the reality, okay. In state office, it depends on the state budgetary, okay. If we can spend more budgetary on the testing, so we can proceed with the gamma interferon testing or the Bobicam kit. So it is more sensitive, and then I think more easy, okay, because those positive, it can save a lot of time with the farmers, okay, to restrain the animals, right, manpower and so on, yeah. So we proceed with the Bobcam, and then those positive results, we back to the field and proceed with the CCT, okay. So there is one thing, okay. Then of course, what kind of sample? Yeah, it's a blood sample that we need to collect for the Bobicam, okay. And then for the necropsy, okay, when we proceed with the postmortem necropsy and or postmortem inspection in slaughterhouse, we have to focus on mainly on lung, okay, lung and lymph node, yeah. And but if in slaughterhouse, for example, because it's very important to determine whether to total condemn, right, or what. So that's why in slaughterhouse, sorry, yeah, typical. This is what we apply. Yeah, in the best we apply total condemn. But at the same time, those organs that reveal or showing lesions, okay, so this should be collect to proceed to the lab for the microbiology testing and also the histopathology examination. Okay, so this kind of sample, okay, for if we proceed to the lab for the molecular, okay, and also the what to say, for the bacteriology solution and so on. So it has to be carried in a appropriate manner, okay, because we have the the guidelines, okay, and follow the lab biosafety and biosecurity guideline. So because we have to know that we are dealing with the risk group, certain risk group which is hazardous to us and so on, right? Okay, and for his stuff, it's quite okay as long as we can we collect it and put it in formalin and send to the lab. Okay, all right. So I move to the disposal of contaminated carcass or tissues. Okay, sorry about that. Firstly, before we talk about disposal of contaminated carcass or tissues, we must understand the rule of thumb. Did we proceed with any virus assessment or not? Okay, because we are investigating, we are doing diagnose and so on, everything to diagnose the disease. But next, what is next? Okay, because we don't want to spread the things everywhere, so we have to know. Actually, the virus assessment we have to do earlier than this stage, because one of the elements of virus assessment is to know what action of disposal that we should perform. Okay, so here virus assessment will tell you what risk group of organism we deal with. Okay, as we know, I'm sure some of us know, some of us might need to be refreshed. Okay, so most of the mycobacterium species are categorized under risk group 2, but different with the Mycobacterium tuberculosis, okay, and also the Mycobacterium tuberculosis complex, including the Mycobacterium bovis, and so on. These are categorized under the risk group 3. So it has to be conduct in a good manner of biosafety and biosecurity procedure. Okay, and based on the DBS FATVM also, there is a general guideline about disposal and disinfection, including the OIE guideline and also the lab biosafety and biosecurity manual produced by the WHO. So after we consider all this, another thing before we start our disposal of contaminated carcass and tissues we need to consider, are we going to dispose these in field situation or in laboratory situation? Because the approach are definitely different. Okay, so let's move to the next slide, please. Okay, when we dispose the contaminated carcasses or tissues, or including our contaminated items, such as PPE and so on, so it can be done by incineration. Okay, if we have the incinerator facility. Okay, I think some of the slaughterhouse also proceed with the incinerator. Okay, and another way is the dig and bury method. Okay, with the calcium hydroxide. So we need to dig, for 7 feet deep, okay, and each layer will be covered by the calcium hydroxide. Okay, it is not just a way to contain the contaminated thing inside the hole, but also to give the contact time for the area not to spread, okay, within the soil itself. They start drain. It's not draining all over the surrounded area. sure you're familiar about dig and bury method, right? Okay, we need to dig for 7 feet deep. Okay, the height, okay, and then we contain all the contaminated carcass and tissue and so on. But prior on that, we covered with as much as sodium hydroxide. Okay, and then we put the contaminated carcass and so on, and then we covered with the calcium hydroxide. Okay, and we bury and we bury with the soil and covered again for the final layer. Okay, but the situation is different in the lab. So if the lab has incinerator, so it can proceed with the incineration. Okay, for TB. Of course, lab biosafety procedure must be applied. So the SOP, because like what we apply, we have SOP that including the way of using the PPE, handle the things and so on. Okay, and then besides incineration, we have the chemical disposal. Okay, most of the lab of DVS lab have this. Okay, since again this Mycobacterium bovis are under risk group 3, and some more when we deal about unknown history carcass, okay, or sample, we have to consider don't to be so safe that, oh yeah, this is risk group 2, let's use Dettol and so on. No, please do not underestimate things. So that's why in all DBS lab, we use the high-end disinfectant such as Vilcon, Lysol, and Distel. Like in my lab at Central Zone Veterinary Lab, we use more on Vilcon and Distel, but depends on situation. If we handle the sample in the biosafety cabinet, we will avoid using of Vilcon on the top of the face of biosafety cabinet, because Vilcon is not friendly for any stainless steel material. Okay, where Distel is friendly use lah. Okay, but if you use other than stainless steel material, yeah, you can use Vilcon. Vilcon can come with a powder form. And one thing, the contact time is very important when we proceed with the chemical disposal. Okay, and of course another way is the autoclaving for the small amount of contaminated tissues and items. Okay, that we can use the autoclaving. Okay, I think thank you. Thank you very much. So back to the moderator. We're happy to listen for any question. Yeah.
Thank you very much, Dr. Muhammad Shafarin from Central Zone Veterinary Laboratory, as well as thank you to Dr. Zawida Zahari, Veterinary Officer from the Veterinary Disease Control and Biosecurity Division, DVS Malaysia, for your in-depth presentation and sharing on TB policies, screening technique and procedures that have been used in animal post-mortem diagnosis and disposal procedures of contaminated carcasses and tissues. If you have, for all participants, if you have any questions or you want to share your views, please reserve until the forum session. With that, this is the end of part 1. I'm thankful to all guests and participants. We will have a short break, about 5 minutes, and we will come back to the second session of the webinar. Thank you and see you in a short while.
Hi, welcome back to our webinar. With me today, we have Dr. Umi Nazira Daud. She's a physician and pulmonologist at Hospital Serdang, Faculty of Medicine, Health Science, UTM. She graduated with medical doctor degree, MD, from University Science Malaysia, and later received her master in medical from UKM. And she had her subspecialty in respiratory medicine from Hospital Chancellor Tuan Muhriz, UKM, ITR KL, Medical Faculty Sungai Buloh Campus, ITM, and Hospital Serdang. So with that, I let Dr. Umi take over for the TB in humans.
Assalamualaikum and very good afternoon. I would like to thank the organizer for involving us firstly in this program. Just now we just had a part 1 TB in animal perspective, and now it's my turn to talk about the TB in human. So I think a TB in human, no need further introduction, because it is other than COVID, TB is another thing that worries us. Okay. Next. So what is TB? For today's topic, we just focus on Mycobacterium tuberculosis. Okay. Mycobacterium tuberculosis is an infection to the human. It's mainly affect at the lung, but also can involve other organs. It is actually a treatable disease. We can treat with anti-TB, unlike the TB in animals. And it is actually a very common disease that we see nowadays. Okay, this slide basically to show you the TB cases in Malaysia from year 2000 and 2017. Basically, from this graph that we can see there is increment in terms of cases that have been notified throughout the years, and it's varying. Okay, so what are the risks of TB? Patients who are at risk at TB, you are at risk for TB when we have close contact with TB patients, especially those who have near positive pulmonary tuberculosis. Okay, in immunocompromised patients, this includes patients who are diabetes, HIV patients with underlying lung disease such as COPD, end-stage renal disease, especially those who require dialysis, malignancy, malnutrition because of the albumin, patients are susceptible to the infection, and those patients who require the immunosuppressant drugs, such as in rheumatoid arthritis, where they require the TNF blockers, and also when they require use of oral steroid more than 10 milligrams per day. Other than that, substance abuse and cigarette smokers and also alcohol drinkers are also at the higher risk for TB. And not to forget, patients who are living in the overcrowded condition. So how did humans get infected? So TB can be infected from human to human via the patient with TB cough, when they sneeze, when they sting, or when they basically from the air droplets that produced by the sputum and then inhaled by another human. Okay. So basically, when human get inspire the TB, the bacilli, the Mycobacterium tuberculosis, what happens is the body start to produce immune response. Okay. Further, it will become controlled infection when the activated immune cells become granuloma. However, if the immune response also can have active infection. This is when patients have active tuberculosis, and at this time antibody responses to the infection. And active infection, of course, can cause transmission and cause infection to the patient and other contacts. So as I mentioned just now, the sites of involvement for the tuberculosis, mycobacterium tuberculosis, mainly 85% are pulmonary tuberculosis, whereas 15% the sites involved from pleura, bones, joints, GI, and other organs. It is still possible, but it's not as common as the pulmonary tuberculosis. So what are the clinical symptoms and signs? So patient an adult who have symptoms of respiratory symptoms more than 2 weeks should be investigated for tuberculosis. Either patient has constitutional or without the constitutional symptoms. So basically, constitutional symptoms means when there are loss of weight, loss of appetite, and fever. And there's also other signs and symptoms that when it suggests of extrapulmonary tuberculosis, it depends on which organ that's been involved. For example, if patient having spine TB, they can have the neurological deficit. If they have the GI TB, they can develop the diarrhea and abdominal pain and so on. Okay, we did prepare tracking for history taking for the case of tuberculosis. I hope this will benefit the audience, especially for the medical students. This is basically to show the basic history that we gathered from the patient with tuberculosis.
Ini kita boleh tutup ni. Boleh tutup. Kita boleh pilih kan.
Sorry for the technical glitch, but we will try to show you the video of the clotting. Which one that you want to? Can the audience see this?
May I know your name? I'm Junaid. How old are you? What brings you here? Can you tell me more about your cough? Do you have any flags? And if you do, what's the color of them? Okay. Do you experience chest pain or difficulty in breathing while you cough? Yes, I do have chest pain. Besides the cough, do you have any fever? Yes, I do have fever. And the fever started immediately to cough. Can you tell me the nature of your fever? The fever on and off, and was at night. So some medication, but still not. Is the fever associated with night sweats, even though we use in an air-conditioned environment? Yes, I do have night sweats. Okay. Besides the cough and the fever, do you experience a loss of appetite or loss of weight? Yes, I lost around 5 kilograms for the past 6 weeks. Okay. Mr. Naim, besides the complaints that you've been handed to me, do you have any underlying diabetes or heart problems or kidney problems? May I know, are you married? No, I am single. When do you live? have any flags? And if you do, what is the color of them? Yes, I would like to have the color as certain customers. Okay. Do you experience chest pain or difficulty in breathing while you cough? Yes, I do have chest pain while I cough. Besides the cough, do you have any fever? Yes, I do have fever. And the fever is started with the cough. Can you tell me the nature of your fever? Even though you're in an air-conditioned environment? Yes, okay. Besides the cough and the fever, do you experience a loss of appetite or loss of weight? Yes, I lost around 1 kilo weight for the past 2 weeks. Okay. Besides the complaints that you've been writing me, do you have any underlying diabetes or heart problems or kidney problems? No.
Betul. Saya rasa dia tak boleh. Yang luar daripada ni ada? Luar daripada PowerPoint.
Tak ada dekat drop lah, tak lah.
Tak ada. So dia saya rasa dia tak boleh nak stay. Sebab dekat saya tu tapi juga.
Itu dia ada.
Yang tadi tu keluar. Sekarang tak keluar. Kedai tu directly luar. Daripada Excel. Daripada PowerPoint.
Tak boleh.
Kalau ada doktor kat saya pun saya download dulu.
Dalam tu apa? Okay, so sorry about the problem with the video just now. So we will try to post again the video later. But I think for now we just continue with the presentation. So basically from the history, can you see the slides? Can you guys see the slides? No response. I hope everybody's still awake. So basically, how to investigate patient with TB. So after we get the history, and if, as I said just now, with more than 2 week history, significant constitutional symptoms, loss of weight, loss of appetite, and we also need to assess the risk for pulmonary tuberculosis. We examine the patient, basically doing the full respiratory examination. And if patient has extra pulmonary symptoms, we should examine to the system that patient is presenting. So how to investigate patient with TB? Basically, the diagnosis of TB by your history and followed by your diagnostic and imaging test. And TB is in pulmonary tuberculosis is confirmed by isolating of the Mycobacterium tuberculosis from the clinical sample. Usually we got the samples from the sputum. And in situation whereby the samples are not obtained, especially in extrapulmonary tuberculosis, certain procedure need to perform to establish the diagnosis. For example, if it's TB spine, you need to get samples from the spine and send for the TB cultures. Okay. So for sputum investigation, basically what we send, if we suspect patient with TB, we send for the sputum AFB direct smear, at least 2 samples, and sputum for MTB culture to look for the Mycobacterium tuberculosis, and as well can tell you the sensitivity towards all the anti-TB. And we can also perform a molecular test, available line probe assay. In patient who have smear positive TB, we send for the line probe assay, basically to look for rifampicin resistance and also to look for the positive of the MTB culture. The next test, gene expert, which you can get it within 24 hours. This is again is a rapid test to look for the positive TB. mycobacterium, and also to look for the resistance. Okay, chest X-ray is important in, it is small. Okay. They want us to the category small condition. Okay, I'll stop sharing first because some said that it is small. Is this okay now? Can you see? Can you see it? Okay, thank you. This, I hope this is better, yeah? Okay. Okay, so from the chest X-ray, basically what you want to do is to look at the parenchyma to see any lines, any fibrosis, because pulmonary tuberculosis usually involved at the upper lobes. Okay, to look for any evidence of lymphadenopathy. I will show you later the examples of chest X-ray with mediastinal lymphadenopathy. Pleural effusion, when you can see the meniscus sign, and then miliary disease, when you see lots of small nodules, and is usually heterogeneous, involving both lung field. So these are the X-ray with the mediastinal lymphadenopathy. Okay. So can you see the arrow here shows there is enlarged of the mediastinal lymph nodes, and the next chest X-ray you can see the cavity at the left upper lobe. Okay. So for grading of the chest X-ray, there are 3 grades: minimal, moderate, and severe disease. Minimal, when you see the involvement of the lung area, very slight lesion with no obvious cavity, only confined to the small parts of the lung. So you comment this as a minimal radiograph involvement. Moderate, when involvement about half of the lung and not more than 1 lung. And advanced, when it's extensively involved, especially in case of miliary tuberculosis. So this actually the very clear X-ray of miliary tuberculosis. You can see small miliates involving both lung fields. Okay. So what are baseline investigation that you need to perform before you start the patient on tuberculosis? You can see from this chart, this flow chart, at the baseline at 0 months before you start the TB treatment. We should have the baseline full blood count, random blood sugar to look for whether the patient has diabetes or not. As I said just now, diabetes is one of the risk factors for tuberculosis. Renal profile, liver function test, because we know after you start anti-TB, there are risks of drug-induced liver injury and also kidney impairment. HIV test, because again, HIV are very higher risk of TB as compared to general population. Sputum FB direct smear at least twice. And then sputum MTB culture and sensitivity as a baseline, because we want to know whether the patient had any resistant pattern at the beginning. And chest X-ray, of course, is mandatory. Okay, how do we treat patient with tuberculosis? Basically, there are 2 regimes. You can see here, daily regime, and another regime is 3 times per week. However, the daily regime is preferred because the risk of defaulting the 3 times per week regime is very high. So how do we give the anti-TB? Is basically according to the body weight. Okay, there's isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin, and these are actually the maximum dose of the anti-TB. And we are now having fixed dose combination pills, where in one pill there's 4 medication inside, and also you have to calculate it based on the body weight. So body weight is important before we start the patient on anti-TB. Okay, to make sure the patient have good compliance, we usually advise the patient for DOT. What is DOT? DOT is actually directly observed therapy. It was launched by the WHO in 1995. It's basically a political commitment to ensure that the patient is taking the medications with good adherence and good management practice. In Malaysia, DOT was reported to be 97%. Not too bad. Okay, and should be a process of negotiation. So you tell the patient, we have to do this to ensure they are compliant. Okay, so the duration of anti-TB in general, the optimal duration of TB medication is at least 6 months. But if patient has extrapulmonary tuberculosis, it depends on the organ that involved. So meningeal TB, it should have 2 months of intensive regime plus 10 months of maintenance. Okay, basically 1 year. Peripheral nodes, usually 6 months. Bone and joint, 9 months. And for pericardial TB, for 6 months. Okay, there's also a question whether we need to start the patient on corticosteroids. So these are the indications for corticosteroid in tuberculosis. Basically, who have TB meningitis, TB pericarditis, peritoneal TB, and TB pleura. Basically, in TB pleura, who in patient, especially with HIV positive, in HIV negative patients. This is to help with the to reduce the thickening of the pleura. So anti-TB is very heaty. It causes a lot of complication and adverse drug reaction. I can't really tell you one by one, but these are the commonest side effects of the anti-TB. Isoniazid, usually we have peripheral neuropathy. That's why in anti-TB with prescription, we also include the vitamin B6. Rifampicin usually cause derange of liver function test. Pyrazinamide, alcaldia maldia, streptomycin, neurotoxicity, nephrotoxicity. Ethambutol, usually we will read about the ophthalmitis. Okay. So just to talk about a little bit on the drug-resistant TB. What is resistant MDR TB? So drug-resistant TB, part of it actually multi-drug resistant TB. What is the definition of multi-drug resistant TB? When patient has resistance to the isoniazid and rifampicin, they should have both resistance, isoniazid and rifampicin. Whereas in XDR TB, they are having resistance to isoniazid and rifampicin, and also to the second line of anti-TB. Okay. How do patients get the drug-resistant TB? It's mainly, number one is acquired resistance. When they have initially tuberculosis, but usually they got MDR when they are actually poor adherence, and dose is actually the medication actually underdose. And for primary resistance, it's not that many, but it happened in the healthy subject. First diagnosis of TB is straight away they get this MDR TB. We call it primary resistance. Okay, what is the problem with MDR TB? Okay, as you can see here, the treatment of MDR TB requires 8 injections per day, and the treatment duration is for 20 months. Okay, and of course the cost is higher, and the cure rate is lesser as compared to the normal normal mycobacterium tuberculosis treatment. And the toxic effect is definitely worse as compared to the first line anti-TB. Alright, maybe that's all for me. If there are any question, maybe you can ask later. Thank you. I pass back to Dr. Sharina.
Okay, thank you, Dr. Umi. As for the video, we will show you later after we try to solve the technical error. So we're going to take like 5-10 minutes break just to set up the video before we proceed with the forum session. Thank you for your patience. Can everyone see this video or is it lagging?
good morning. I'm Dr. Nia. May I know your name? How old are you? What brings you here? Can you tell me more? And if you do, what is the kind of the experience has been, or the difficulty in reading, what is it? You had the cough. Can you tell me the nature of your fever?
Okay, yeah.
The fever associated with what? Even though you've been in besides the cough and the breathing, you experience loss of appetite or loss of food? Besides the complaints that you face, do you have any underlying diabetes or heart problem or kidney problem? Yeah, I know. Are you working right now? I have to ask you some scientific questions. If you don't. Do you smoke? Do you drink alcohol? Do you take any recreational drug? Do you engage in a sexual life? Are you taking steroids or do you have allergies to any medication? Is there any of your colleagues or family members who are diagnosed with this disease? Or do you have any contact with tuberculosis? Thank you, Mr. Naimi, for this book. So based on the presenting form, I can say that it might have a head impact. However, I need to perform a limited examination to run some investigation to confirm.
Okay, we shall resume our forum at 4:20. Thank you. Meanwhile, you can just drop any questions that you would like to ask. Welcome back. We shall proceed with our forum session. So, with here today is Professor Dr. Shafinas Aminuddin, Professor in Medical Microbiology and Head of Department of Medical Microbiology and Parasitology from Faculty of Medicine and Health Sciences, UPM. Her research interests include zoonotic infections and One Health. So Professor Shafinas will become the moderator for this forum.
Okay, thank you very much, Dr. Sharina, for the kind introduction. So we will have our speakers back for the forum. So if you, the participants, if you have any questions, please feel free to type in the chat box so that we can read your questions, and I will share with the panelists that we have today, which include our speakers. And before we start, I would like to introduce two more panelists who are going to share their expertise in this forum. First, we have Professor Dr. Saleha Abdul Aziz, who is a professor in veterinary public health. She has been involved in research on zoonotic bacteria, in particular those that are foodborne related. And Professor Dr. Saleha has been invited as panel speakers in a number of conferences and seminars. All right, before we start the sharing from our panelists, is there any questions in the chat? Okay, so far we have none, but feel free to ask questions to the panelists and also to the speakers. All right, so maybe we will start with Prof. Dr. Saleha. So far that we have heard the perspective of tuberculosis in animals as well as in humans from our previous speakers. Perhaps Prof. Would like to elaborate further tuberculosis with respect to the food that we consume, especially with relation to meat from animals. Maybe Prof. can share your experience with us.
Thank you, Prof. Safina. Assalamualaikum and very good afternoon. First, I would like to thank the organizer for inviting me in this forum. Well, that is to say, when you talk about food safety in terms of food of animal origin, we talk about safety of meat and milk, and especially when we've got infected cattle, which is quite, in terms of when you talk about tuberculosis, mainly in cattle, although there have been reports of tuberculosis in goats as well. But with regard to meat, as we have heard our expert from the Department of Veterinary Services mentioned that once the animal is detected as positive, they will be culled. In other words, it is test and culled, and therefore the animal should not be slaughtered. It means even though the animals may be positive but they do not show any symptoms, but from what I've heard from Dr. Shafarin, that they have to be disposed of. It depends on some countries where they allow, if the animal are suspected, infected, if they are infected but without any symptoms, but if there is no tuberculosis lesion, then according to this, in Ireland, they allow the animals to be part of food, but I think it's not for us in our country. But if they found out more than one lymph nodes or the regional part of a carcass as affected, if more than one, then of course it will be totally condemned. Otherwise, it is only partially condemned. So it depends on the country. But for Malaysia, well, from what I've heard, it is test positive and culled. Now, in terms of meat, that means there is a possibility that the occurrence of the organisms in the meat. I'd just like to add on for milk, there could be a possibility of the infection from drinking raw or unpasteurized milk, because it depends again on the culture of the person in the country. Some would like to prefer raw milk, but unfortunately it's not safe, and therefore the milk require heat treatment. And otherwise, you may get infected because the organism is being excreted in the milk as well. And also in other countries, they prohibited the use of unpasteurized milk for dairy products. For example, US and EU banned the use of unpasteurized milk for dairy products such as cheese, yogurt, and so forth. So in other words, well, once the animal is infected with TB, they have to be culled.
Okay, thank you, Prof. And perhaps I can ask questions to our previous speakers, perhaps to Dr. Zawida or Dr. Safarin. Just now, one of you mentioned about workers. Could you please elaborate a little bit when you mentioned about workers? Are these workers related to animal handlers? Are you still there, Dr. Safarin or Dr. Zawida?
Hi, thank you for the question. About the workers, when I mentioned that we need to give some awareness to the workers, It is the workers that handle the animal handlers, which have close contact with the animals. So if the animals are tested positive, so that we give awareness to them to say that if they have symptoms, they need to go to the clinic or to the hospital to get themselves checked for TB, because they have the case in the animals at their working place.
All right. And is there any preventive measures that they can do if, let's say, when they are handling the animals, right? Is there any protective clothing or any protective equipment that they can use?
For basic workers, cleanliness and PPE, they need to have the awareness of cleanliness for themselves before and after handling the animal. And for animal workers, they can use basic PPE like face mask and gloves. But they need to be reminded regularly by the bosses. So they need to do that practice often. But in reality, they do their work as comfortable as they want. So it's the responsible of the superior or the employer to check on that, how the workers handle the animals, if they do the cleanliness for themselves regularly.
Is there any specific face mask that they should use?
No. Because of the COVID-19 now, so everybody knows of face mask. But for this kind of situation, there's no specific face mask that they need to use to handle animals, because in the first place they don't know the animal is infected. They don't know.
Okay. Prof. Saleha, anything to add to that?
I guess not. As you mentioned, with the face mask, at least to protect them from the aerosol transmission. But from what I've read as well, they have to be very careful, because there's also cases of transmission through percutaneous transmission. In other words, the tubercle bacilli can get through the cut and abrasions in the skin. They do have cases reported as such. So that is another thing that we need to look into.
Okay, thank you.
Is that Mycobacterium tuberculosis?
Yes.
Okay. All right. So my next question will be to Dr. Umi. So just now, Dr. Umi started your lecture with saying that it is common. I mean, the disease is common. TB is common in human. So let's say if you have a figure, the frequent, how common is common? Maybe in globally as well as in Malaysia?
Okay, thank you for the question. I can't remember offhand how many that we got so far, but I did show the graph that from 2007 until now, the number has been increasing. So roughly, if we are at the outpatient clinic, I would say in a week we see about 3 or 4 at least patients who suspect with TB.
Right.
It's very frequent and it's worrying.
Okay, so on that note, it also related to the workers in animal, those who handle animals. How about those working in healthcare setting? Are they also, is it quite common for those working in healthcare setting to acquire this disease, tuberculosis?
Yeah, of course, for healthcare setting, that's when we have the words of latent tuberculosis. I think as well as the veterinary officers as well, because if you expose to the disease, it's already in your body. So if we do the METU test or we do the IGRA test, it will be positive. Doesn't mean that you have the infection now, but it is in your body. It remains dormant. So when will you have the active disease? It's usually when your body is immune system drop. Okay, let's say if one day you got diabetes, one day you have cancer, at that time your TB will come up. Okay, so what usually we do, of course we advise precautions, you need to wear N95, not the normal mask in handling patient with tuberculosis, because you know it won't work. And second, healthcare workers, we do the Mentu test or IGRA test to look for the latent, and they are at higher risk, so we usually advise them for prophylaxis therapy with isoniazid for 6 months. This is to prevent. They tell that the risk of latent TB to become active is about 10% throughout the life. I'm not sure about the veterinary. Maybe it's good case to study with the latent TB in vets, because I'm sure you're not wearing the N95 when handling this.
Yeah.
Okay, the risk of latent is high.
Okay, and is there, because the fact that it's latent, so is there any strategies of screening among the healthcare workers?
Yes. We do the screening for patients that we think will require the treatment, the isoniazid prophylaxis treatment. Okay, basically those who require is healthcare workers, and then who are HIV definitely, who are require high dose immunosuppressant. Okay, those who contact with TB, especially smear positive TB, we will do the screening. Other than that, if you like just want to do it suka-suka hati and it turns to be positive, sometimes it's not necessary to treat because you are at not the higher risk as compared to this population that I mentioned just now. So we cannot screen everybody. Because I'm sure the risk of exposure in Malaysia is very high. So we screen for those who we think that we should treat for the latent TB.
All right. So, okay, so on that note, maybe I get back to Dr. Zawida, because just now you mentioned about surveillance, right? Okay, so are there any challenges with surveillance that you face when you do these activities?
What kind of challenges?
Do you have any, so far, so who are involved in the surveillance, and if there are any issues or challenges that you face that hopefully can be overcome to somehow make the surveillance more effective?
Okay, as I said earlier, that we have the annual surveillance program that is planned and calculated on how many samples to get and how where to go and how much samples, and usually the field work were done by the state officers to get the samples as we planned, and it's one of their KPIs also. So they must do as good as much as they can to fulfill the KPIs and to go according to plan. So if we plan it as thoroughly as possible, including the budget, the test kit, the TNT and everything, it will go smoothly by plan. But the challenges might be like this year, we have COVID-19, of course. So within the PKP time, for long months, like 4 months, so the plan is disrupted. So we cannot go through as planned. So we have to tunda everything. So somehow they cannot get that numbers of samples as much as 100% for this year. So that's one of the challenges for this year. So other challenges is like sometimes they cannot get cooperation of the farmers sometimes, but most of the time they give the cooperation. But sometimes there's some farmers yang degil-degil ni, they didn't give cooperation, so we have to get an alternative to get that sample, maybe from another farm, or we persuade the farm to give their cooperation to get the surveillance sample.
Okay, yes.
Okay. You want to add?
Yeah. Perhaps I make one addition point here. Talking about challenges, one thing from the laboratory perspective that I noticed is that the sampling is being carried out by the trained, experienced district personnel of DBS. But in order to the time after sample collection to the lab, when we mentioned about the Bovigam testing, the gamma interferon testing, so they have stipulated time to make sure that the sample will arrive to the lab because of the procedure of the testing itself. So to me, that is one of the main challenge for the field people. Yeah, intercorrelate with the lab. Yeah.
Okay, all right, thank you. So actually there's one question to Dr. Umi from the participant. So if I may read the question. How to confirm whether the positive ASB smear in human is due to human TB or animal TB? Is there any prevalence of human TB case originated from animal TB, such as Mycobacterium bovis or Mycobacterium avium in Malaysia? So perhaps to Dr. Umi and maybe the rest of the panelists can also share your experience about this. Dr. Umi, you may start.
Okay, for the whether to know the positive TB is from human or from animal, basically what I know is from human lah. I'm not sure about the from animal, because the how did human get TB is from air droplets from other human with positive TB. So maybe it is less evidence or under evidence whether it is actually arrived from animals. I'm not sure. But for Mycobacterium per se, I will say most of the time it's from human.
Okay. Human to human?
Human to human with the air droplets.
Okay.
Okay. And whether it is originate from other, so we call Mycobacterium bovis, avium, fortuitum, abscessus, all these are actually, we call it as atypical Mycobacterium. This is not like Mycobacterium tuberculosis. And in fact, we don't really notify it because it is not infective to other humans. Meaning if you get the fortuitum, for example, or bovis, what I know lah, I might be wrong. It didn't actually infect to you because it is not from the air droplets. It is this avium, bovis, all because of the contaminated fluid, like the milk, the water, I think the avium is from the fish, the aquarium kan. So people get it from the cut wound. They didn't get it from the inhaled droplets. Okay, because I don't think that the fish cough and I don't know how they get. Okay, so we call that atypical Mycobacterium, and the treatment regime is different as compared to Mycobacterium tuberculosis.
Okay, perhaps Prof. Saleha or maybe our speakers from DBS would like to further elaborate on that?
Maybe I would like Dr. Shafarin, you go ahead first.
Sorry?
Do you want to say to comment on Mycobacterium bovis in human? Would you like to comment on that?
As I mentioned earlier that okay, based on how to say case report, very seldomly or hardly to hear that the case from the animal to human, right? For the tuberculosis. But again, when we refer to other country situation and then what being portrayed by the oil itself, okay. So yes, there was cases. Sorry, there were few cases related with the animal to human. Yeah, like I mentioned earlier, when if we consume the contaminated milk, for example, unpasteurized milk, okay, and if we get contact with any contaminated droplets or aerosols from the infected animal, yeah.
Maybe I'd just like to add on, when you talk about countries like Malaysia, we are considered as, or shall we say, we are going into the developed country. But when we talk about bovis or bovine tuberculosis, it's more for the underdeveloped countries, or let's say like in Africa and certain countries in Southeast Asia. From what I've known, they are, because of their close contact with their animals, so they are easily infected with Mycobacterium bovis. So you say airborne transmission, and also most of them would like or prefer raw milk. So we don't see here in Malaysia. Okay, so there is quite a number of cases actually of this bovine tuberculosis, and from what I've heard, it's increasing. And the thing that I would like to share also, it's not only when we talk about cattle, but now there are also other animals involved.
Okay, hopefully, Dr. Yasmin, is there anything else that you would like to be further clarified from the police? Okay, the questions that they have offered to you. The question was from Dr. Yasmin.
Sorry, I just want to add. I think that the prevalence, I think is not off lah. Maybe that we can consider doing it lah. Yeah, we have cases with atypical bacterium, but the numbers, the prevalence in Malaysia is not well documented lah, I think.
You mean this one is in human?
Yeah, in human.
Okay.
Yes.
All right. So on that note, because Dr. Ufi talked about notification, so actually we have another panelist with us today who has just joined us, because actually our forum started ahead of time just now. We started earlier. So we have with us also Associate Professor Dr. Malina Osman, who is a member of our specialist with specialty in epidemiology and biostatistics. She is from the Department of Medical Microbiology and Parasitology, Faculty of Medicine and Health Sciences. And she was also an assistant director in the Ministry of Health before joining Malaysia. And her research is mainly in tropical and infectious diseases, and she is also known to the public for her expertise through her written and opinion sharing in mass and social media. So, Dr. Malina, could you elaborate also on notification, especially with respect to TB in humans?
Okay, Assalamualaikum warahmatullahi wabarakatuh. My apology for joining this forum quite late. Related to the question, related to prevalence, Dr. Professor Finas?
Yeah, and also notification.
Okay, in terms of TB in general, I just would like to share based on my experience as well and my discussion with officials from Ministry of Health recently. Mainly those notified to Ministry of Health are all those human tuberculosis. There is none zoonotic tuberculosis has been notified, I think for years, never been documented except for some of the studies being done in some of the universities. So basically in terms of notification, it is governed under CDC Act 1983 and then being improved recently for most of the infectious diseases, of those notifiable diseases. And then it depends on when would be the sources of the notification, from the district health office, from the clinics, as well as from the hospitals. Usually we gather the information after the diagnosis being confirmed. And then following that, the contact tracing as well as all the surveillance related to the cases that being notified will be done accordingly. In terms of strategy, for your information, Ministry of Health recently in 2015 had implemented the national health policy on strategizing to improve the notification of tuberculosis via 7 strategies. And one of it, the strategy number 1 would be the enhanced case detection of tuberculosis. And for information, we initially in ministry, I think about 20 to 30 years ago, we have centralized mode of notification where we have only Central Tuberculosis Center, National TB Center in Jalan Tun Razak, but later on they had changed the policy, which we observed that a lot of weaknesses following that form of notification. But then with this new strategy, it is hope that the enhancements of notification will be much better and more people will be treated accordingly and monitored much more effective.
All right, and maybe just to add to Prof. Salha, anything to add? Okay. So maybe to Dr. Marina again, and afterwards to the rest of the panelists here, because the speakers also mentioned something about just now the animal handlers that they didn't give their cooperation. And Dr. Marina, also from your experience, what do you think about awareness of maybe public or those in working with animals or those in healthcare settings? Do you think that our awareness okay, or do we still need to somehow have education to improve the awareness of the public further?
In general, across of all those infectious diseases, we still find a problem related to behavioral approach. Most of our individuals in our community, they had a very much poor insight related to all those prevention that tie to behavior, particularly in their lifestyle. We actually face a lot of problems related to TB, because TB is one of the documented, the highest prevalence of deaths due to infectious disease is caused by tuberculosis. And related to TB, the problem is that the poor compliance relatively to the treatment that need to be attended every day for all patients. So because of the poor compliance may lead to all those inevitable outcomes, and most of them are perhaps unable to be treated because they come mostly at the terminal stage. Related to zoonotic, to me, with the advanced technologies in Malaysia, we do not have very much problem related to it, because we have a proper, I think, the pasteurization of those milk and the product of the animals. Unlike like other countries in Africa that have been reported many of cases related to all those agriculture and the domestic animals. So I think perhaps we must have a proper interventional modules to increase the awareness regarding the importance to take care the preventive aspects of the tuberculosis. One more thing that we should aware is that during this COVID outbreak, to my opinion, the probability of the fatality related to tuberculosis may be increased. Not only because the TB is one of the most common infectious disease that usually end up with fatal outcome, but then those with double infection may also lead the probability of increase in terms of mortality.
Okay, thank you. Just now, Dr. Marina mentioned about interventional strategies, right? Any suggestion or any examples that we can perhaps?
I think what we can do is that from time to time, the study as well as to determine the insight, particularly on awareness related to this infection, should be done so that the appropriate strategy to increase the insight as well as their compliance toward the treatment can be achieved. This cannot be done only once. This should be continuous, particularly those who are educated. In general, from public health practitioners, we found this is very difficult because we are facing the new generation where they feel that they are educated, but sad to say, some of those facts related to health not being understood very well. I give an example like vaccine. We face a lot of problem with all those against the vaccines, particularly in this tuberculosis. We also have vaccine, BCG, but because of the poor turnover among those who are not well informed related to adequate information leads to all those poor compliance. And I think that all of us should hand in hand help each other in order to make sure that all those individuals in our community to be informed appropriately regarding all those risks as well as all those complications related to this infection.
Okay, anything that maybe Prof. Saleha would like to add related to veterinary medicine, maybe?
Maybe I would just like to share a little bit of the news that I got what shall I say, when we talk about especially Mycobacterium bovis, okay, it's not only in our livestock, but we also found it in our wildlife. So I talked to Dr. Azlan recently, he's not around here, and he's working on wildlife, he's our wildlife expert, and he told me that they do find Mycobacterium bovis in wild boars and also in monkeys, and they are working into it. And one thing that I would like to share is that, with wildlife coming in, enriching into our habitat, we just wouldn't know what would happen. I would like to share with you the 2 slides that I have. It's just to bring awareness, nothing else. Okay. One is just to summarize on the modes of transmission that we have. Just to share with you, I just found the paper on this. It's very interesting. Just that with the cattle as the reservoir for Mycobacterium bovis, then it can spread to other livestock, also our pet animals, dogs and cats, and also to human through airway transmission, and as we mentioned, through unpasteurized or raw milk. But now, where do these cattle got this Mycobacterium bovis? We are looking into from the wildlife. So what they have here is the deer and the badger, but then from Dr. Azlan mentioned, wild boars and also from the monkeys. So we need to look into our environment, all right? And then there's one last one that I would like to mention, very interesting from London, when the other one. He said, my cat gave me TB. So I look at the paper, and on investigation, they have 9 cases of M. bovis in cats and 2 cases in humans. And what they found, the Mycobacterium bovis in those 2 humans and cats are very much similar to molecular analysis. And the source would be likely from the wildlife, but I would say also from the environment, because the Mycobacterium bovis can withstand about 2 months to 3 months in the soil and water. But of course, with a high temperature, they will be killed. But although the risk is low, but according to the animal TB, companion animal TB team in University of Edinburgh, the cases are increasing in cats now. They have very high cases of Mycobacterium bovis in cats due to being fed with a raw meat-based diet. There is a tendency now also in our countries. If you go to the pet shop, they sell commercial raw meat-based diet. So it's just to bring awareness. So we have to be very careful, because when I look into our cats now, they seem to pick up everything from the environment. Initially, when you talk about Tuberculosis, it was just environment, but now cats are picking them up from the environment and now passing it to the human. So, with our close association with cats and dogs, we have to be very careful. Don't say that it won't happen, because nowadays we just cannot predict anything. So we just have to be careful. Thank you very much.
Thank you, Prof. So basically, Dr. Malina and Prof. Saleha have shared in relation to public. So our participants are mainly students from both the veterinary and medical students who are our future One Health workforce. So maybe I will pose my question to Dr. Umi first. Anything that they can do, what can be their role to address the issues that have been raised by both Dr. Malina and Prof. Saleha?
Okay, thank you for the tough question. Basically, me and Prof. Maha had done a study. We conducted a study to look at the student KAP, knowledge, attitude, and practice towards TB. So basically, we compare the preclinical and clinical students, and we find that it's about the same, their knowledge, attitude, and practice. And then even you go preclinical and clinical, the outcome are about the same. But in general, is not to the standard yet. So I think what important here is education. Education at the university is very important before they go to the clinical setting, so that they have less exposure. I mean, they know how to take care of themselves, and then basically to reduce the TB among the healthcare workers.
Right, and then from our speakers from DVS, anything you'd like to add to that? The role of our future One Health workforce? Dr. Zawida or Dr. Safarin?
Dr. Shafinas, may I ask a question?
Sure. Yes, please.
My apologies, I did write it on the chat, but I think it's missed. My question is, I saw the increasing trend of TB cases for the past few years. So is there more granular kind of analysis by which you can actually divide those cases by occupation and also by their nationality? Because we do have many foreign workers coming in from hyper-endemic countries, and many of them are located at the farm. So my worry is that for cases in animals, in our livestock, and in wildlife, is actually emerging and emerging in very, very closely to how it is emerging in human population in Malaysia. So my worry is that if we place workers that are TB positive, our animals will end up having TB from humans. So based on the recording of the interview just now, that wasn't very clear, and I guess it's not finished. I did not hear questions about occupation and also about what do they do for a living, and then whether they have been interacting or consuming animal products, and then also if they have been to countries that are hyper-endemic for TB. So are those questions asked? And then in the analysis for TB cases at the national level, can we know from a more granular kind of analysis what is the proportion of those cases that are coming from countries that are hyper-endemic, and also having occupation that is related to animal health or animal industry for that matter? Thank you.
Okay, perhaps Dr. Lee would like to start. Maybe maybe Dr. Malina? Because this is like I guess, Dr. Malina?
Okay, related to the national surveillance on tuberculosis, what usually they have would be on the high-risk groups, yeah? The high-risk groups include those who have HIV, comorbidities, inmate for the prisons, diabetes, patient who smokes, failure in dialysis. Majority on all those high-risk classifications, yeah. But basically on the occupational, from the occupational setting, I'm not sure whether Ministry of Health had compiling it or they just put it as part of the study. And then in terms of notification, as well as for the foreign workers, as you know that we have FOMEMA, who usually would screen the new workers, the foreign workers into certain procedures, and one of it, the TB will be screened, and then the data will be provided by FOMEMA to the Ministry of Health for the purpose of notification. But in terms of treatment, I'm not sure. Usually it will be sponsored by the employers, and then majority of them would have treatment accordingly, whether from the private clinic or the government. So basically the data for tuberculosis for our country mainly governed for our own population rather than for the foreign workers. And we did face some of the problem for those who are illegal foreign workers. None of the documentation related to them. And I had some unofficial data related to those who are not properly treated, We did study Gombak recently. Some of those data, basically of those foreign, were not treated well, so that producing or providing some of those exposure to the public, particularly in certain areas. That's the areas that we should concern. And then I think more study on tuberculosis be initiated and related to many foreign workers that are existing in our countries.
And that would also include the foreign workers who are in livestock farms, Dr. Malina?
Yeah. Yes.
Okay. Dr. Prof. Latifah, is there any question that need to be clarified?
Maybe just one more follow-up question. For Mycobac TB, the atypical tuberculosis that you mentioned just now, Dr. Umi, does that include also ones that are due to Mycobac TB complex? Or is that like something different?
Basically, the pulmonary tuberculosis is usually caused by Mycobacterium complex. Other than that, we call atypical Mycobacterium, which include the other types of Mycobacterium, including the abscesses, the fortuitum, and the rest, because the treatment is different. And the manifestation also different. It's not the same.
So in my reading, I might be mistaken, that Mycobacterium complex is also can be caused also Mycobacterium bovis. So it's not necessarily that Mycobacterium bovis cause atypical. It can also cause the regular tuberculosis in human. Is that correct, or am I mistaken?
I think the organism itself is different. Mycobacterium complex is different, and Mycobacterium bovis is different. So in human, what common is Mycobacterium complex. Because it is different thing. It's a different organism that causing manifest the tuberculosis itself. So other than Mycobacterium complex, we call it atypical Mycobacterium.
So this belongs to the complex?
Yeah, no. Complex is Mycobacterium complex is one organism cause the Mycobacterium tuberculosis. Other than that, considered atypical. Okay, is it clear?
I may be mistaken in my reading, but I'm very sure that Mycobac TB complex comprises of several species of Mycobacterium, including bovis, tuberculosis, caprae, and a few others. Other people can correct me if I'm wrong.
I tend to agree with Prof. Latifah that in fact now they are still working on the classification of this Mycobacterium organism. As you mentioned, Mycobacterium tuberculosis. In fact, they are going to name it like Mycobacterium tuberculosis subspecies bovis, and then Mycobacterium tuberculosis subspecies bovis. So it comes under that complex as just mentioned. And they have another complex where they have Mycobacterium leprae. There's another group. And the third group will be, as mentioned, the atypical Mycobacterium. So it is still evolving. And but yes, bovis, they put it together under Mycobacterium tuberculosis because to us, being a vet, to us, we look at similar. Because in the setting of human-animal interface, we also have cases where the elephant conservation place where the workers were infected with tuberculosis and transmitted to the elephants. So the elephants were infected with Mycobacterium tuberculosis. And of course, those elephants had to be put away. I mean, not disposed of, but put away. But they cannot be exposed to the public. So to us, as a vet, I agree with Dr. Latifah that they are under one complex.
I believe just now, I think Dr. Safarin or Dr. Zita has also listed a few of the issues from USHS.
Yes. Yeah, it was. Yeah. And my point also, I also agree with Prof. Latifah and Prof. Saliha. Yeah.
Okay, and there's one more question for Dr. Umi from Yusri. He would like to ask regarding the smear negative pulmonary tuberculosis. What further management that needs to be done? The last question. Yeah.
Basically, for pulmonary tuberculosis is divided into two groups, smear positive and smear negative. If smear negative, we have to make sure that this is true TB or not. So we have to further investigate, and that's why we have to send the culture. Sometimes the culture later come back as positive, so it confirms that this is TB. But again, we have to look into the general situation. We have to look into the presentation symptoms and with the radiological symptoms lah. Before there are some cases that we can't really wait, because for the MTB culture to come back, it takes 2 to 3 months. So before we got the culture positive, we usually treat the patient. That's why we label as negative TB, provided the symptoms and the radiological actually classical of TB.
Okay. All right. Hopefully that answers your question, Lucy. And there's one question from the people here to our speakers, our colleagues in business. Is there any animal transportation policy that is available with respect to tuberculosis and One Health? Animal transportation policy.
Transportation.
Okay. Maybe Dr. Hamza? Yeah.
Okay. For normal times, without any outbreak or anything, we do have a permit system for any movement of ruminants from point A to point B. So to get the permit, the animal needs to be checked at the origin with no clinical signs and everything to get the permit to go to the point B for slaughtering or for breeding. So if there's a case of disease, any kind of disease actually, so we have to control where we have the authority to not allow the animal to go out from the infected area. It's quite noisy in the audio. Sorry. Somebody is blending something. Yeah. If there's a disease, then we have the authority to do the movement. So no infected animals in something. Yeah.
Okay, how about animal importation or importation, right? The question was?
Import.
Animal products? The import of animal products. Yeah. Sorry, screening. Okay. Yeah.
All right. Let me introduce myself. I'm Sabaria from TVS, taking care of regarding about importation and exportation of animals and animal products. Okay. Regarding about importation, of course, definitely we will follow based on OIE guidelines or given to us. Okay. So for the cases, of course, we have to import from the certificate whereby it's free from TB, or otherwise they should come out before they're exporting to our country. Okay. For your information, before we allow any importation, definitely so that we develop the procedure of importation. The import condition must be complied by the exporting country. Okay, is it sufficient enough?
Okay. I believe that that have answered their questions. We have come to the end of our forum actually, and in my opinion, that's been a fruitful discussion. And thank you everyone for the good, the interactive session that we have. If somehow we miss a question, please feel free to unmute your microphone, and you may also ask us directly. But before we end, perhaps we can have a conclusion from each of our respective panel. So shall we start, Irina, we start with Dr. Malina. Is there any concluding statement from you before we end?
Okay, in terms of prevention, no doubt that the collaboration between the veterinary medicine as well as medicine in general need to improve our insight related to the infection of tuberculosis, as well as on how we should act towards the compliance of the treatment, and reduce all those mortality and morbidity related to the infection, so that our junior future doctors from both fields should work together in order to have a better outcome in your time, inshallah.
Thank you, Dr. Marina. And Dr. Lee, any concluding statement from you?
TB is a very frequent disease that happens in Malaysia. So I think the prevention is very important. So education is very important, especially for clinical. Our students going for the clinicals soon.
Okay, and Prof. Salia?
Yeah, now it is very interesting now that we are talking now about zoonotic tuberculosis. Initially, if you only talk about Mycobacterium tuberculosis, now Mycobacterium bovis is coming into the picture. So we need to be aware of our animals and environment, and hopefully we can together, when we talk about animal health, human health and environmental health, we can work together through good collaboration and prevent the disease from spreading. Thank you.
And Dr. Zawida, Dr. Safarin? Maybe both of you?
Okay. We think that beside all the points just now, more documentation on test report, study, etc., are really needed for better understanding on the TB infection.
Thank you, Dr. Safarin. Dr. Zawida?
Well said by Dr. Safarin. Just want to add about the future vet out there, maybe besides this screen, to be more knowledgeable and to be more aware on what the government did to the country to protect our animals.
Thank you. Dr. Sabaria, is there anything from you also?
No. I think it has been stated by Dr. Safarin.
All right, thank you.
Well,
okay, I guess that's all from me. I would like to now pass back the session to Dr. Sharina. Thank you, everyone, but please stay with us still. Yeah, thank you. Thank you, panelists.
Thank you. Thank you. Bye. Assalamualaikum.
All right. Thank you, everyone, for your patience and then for your participation for today's webinar on the section of tuberculosis from the animal to human perspective. So what I've got for the conclusion is that education is the key of everything. So educate ourselves, the professionals, so that we are able to educate the farmers or workers out there on the possibility of the zoonotic mycobacteriosis. And this is one way to prevent from the spreading of the disease itself. And perhaps in future we could gather more information through collaboration in identifying what species is actually causing the spread of mycobacterium. Is it MPD itself or M. bovis? Because and that can actually improve the history taking to actually detecting the infection at earlier stage. So with that, before we leave the meeting, I would like to remind you again to do the post-survey questions, which has been given in the chat box. The link is in the chat box. So you can also suggest on what to improve or what would you like to cover in future events regarding this tuberculosis detection or diagnosis. Okay, with that, thank you all and hope to see you guys in future.